Good morning or afternoon, everyone, depending on where you are. This is Unica Lewis with JBS International, and I would like to welcome you to today's Trends in HIV Prevention and Care. Before we begin, I would like to review some housekeeping items. Due to the high number of participants on this call, all lines will be muted during the participation of this webinar. If you have any comments or questions, please submit them at any time using the Q&A feature. To open your Q&A window, please click the Q&A icon located at the bottom center of your Zoom window. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or you can email us at rcore-ta@jbsinternational.com. We will request your participation in a short evaluation survey that will be sent via the chat box towards the end of the webinar. We'd like to thank you in advance for your participation in this webinar, as well as the satisfaction survey. Lastly, this is a recorded event, and your participation grants consent to be recorded. The recorded webinar and the PowerPoint slides will be available and sent to participants at a later date. Today's presenter is Jim Sacco. Jim Sacco, with an MSW, is an HIV subject matter expert with JBS International. He has been involved in HIV prevention and care activities since 1984 and has collaborated with the World Health Organization, USAID, the U.S. Centers of Disease Control and Prevention, Duke University, Emory University, the University of California, San Francisco, community groups, and state and local health departments. He has trained more than 50,000 healthcare workers since 1986. Jim, I'll turn everything over to you.
That's great. Unica, thank you very much. I'm going to say good afternoon since it's 2 o'clock in North Carolina. People that joined us after we started snuck in at 2:01, we are saying hi to one another down in the bottom right in the chat box. As Unica said, we're going to do the chat function down there. So if you've got things you want to say, but all questions go in the Q&A box, and I'll stop once in the middle for questions and answers, and I'll stop again right before 3 o'clock Eastern time to do that. So welcome everybody. We're going to talk about federal funding for HIV prevention, or talk about tools. The bottom line, the context for this meeting is there is a funding opportunity that's available for people to do rural HIV planning. And we talked about it within JBS and thought some of our folks are in the right position. They're doing coalition. They know the right partners. They're connecting different parts of the community. Wouldn't it be great to give them an opportunity, some information that could help with that particular application? So full disclosure, there's a current funding opportunity. Your TEL can get you more information about that current opportunity to do rural HIV response, sort of a planning grant there are going to be 10 awards. More than that is two things that come to mind. There's a real need to increase. You'll see as we go through the talk, there's a real need to broaden our response, including outside of urban areas, including some other places. I think you guys are in an important position as rural OUD providers to be responding to people at risk for HIV prevention, and helping people with HIV stay in care, get in care, maintain the benefit of good treatment. So it's definitely about this one funding opportunity. It's also about the possibility that you've got people who are currently getting services that could benefit from your expanding. Glad you're back, Denise. So that's what we're here to do. We're going to have a little fun. We're going to get to know each other in the chat box. Again, formal questions in the Q&A. I'll stop twice, but if you want to just say hi, go down there in the chat box. So federal initiatives, big picture again, we're just trying to make sure everybody's on the same page in terms of what the federal government is asking for. If you are at all interested in expanding what you currently do in HIV prevention or care, or want to talk to people, or certainly if you're writing a federal application for funding, you need to say the following. We are helping the government implement the National HIV/AIDS Strategy. We are addressing the HIV care continuum, and we're going to participate in ending the HIV epidemic. These initiatives and the funding that goes along with them are really the way the government does business around HIV prevention and care. They're also the right thing to do. I'll go through these in good detail in just a minute, but essentially every funding opportunity, every conversation you have with a community partner, you're meeting with a health center in town, you're meeting with the health department, you're shaking hands, you want to say, we'd love to help you with the AIDS strategy. We'd love to help you address that care continuum. We'd love to help you with your ending the HIV epidemic initiative. Okay, so National AIDS Strategy goes back to 2009, 2010, during the Obama administration. 4 goals of the AIDS strategy: we're going to reduce new infections through HIV prevention. I'll talk more detail about that. We're going to improve access and health outcomes. Part of what is concerning and what draws this, where this draws from, is that certain people living with HIV, particularly you'll see persons who inject drugs, individuals outside of urban areas, other youth, transgender individuals, have poor access and health outcomes that are not acceptable. And so trying to address some of the gaps that exist. Reducing health disparities is the third goal of the AIDS strategy, and achieving a more coordinated national response. Basically what this means is, under the National HIV/AIDS strategy, the federal government and its partners are trying to make sure that one arm knows what the other arm is doing. So in terms of what is embedded in the AIDS strategy, what the federal government is saying, the first, and I would argue one of the most important, is HIV testing and linking people to care. What's important about that slide is those two concepts are absolutely joined. You'll see in a minute what we now know as we study sort of what happens. I would have just said, just test people with the assumption that everybody gets to an HIV care setting. In fact, there's real concern that a bunch of people, I would guess a bunch of people that you know, a bunch of people on your caseload are being tested and aren't being retained in HIV care. So again, testing and linking people to care so that they can benefit from treatment. Full access to pre-exposure prophylaxis. If it's been a while since you've thought about HIV prevention, I think what's really important for you to understand is there are still behavioral interventions, support group interventions, individual interventions, but there's an enormous push towards biomedical intervention. These once-a-day pills, there's 2 currently licensed, provide 99% protection. So in other words, where you used to have to remember to use a condom or clean needles every time, and doggone it, now it's 3 in the morning and where are my needles and whatever else. If I've taken my PrEP that morning, there's not protection from hepatitis and other STIs, but if I'm taking that dose every day, 1 pill once a day, I'm up to like 99% efficacy for protection from HIV, even if I have unprotected sex or share injection drug equipment. Support for people living with HIV is the other important part. This means figuring out why people are having difficulty staying in care. You'll see some interventions in just a minute, but sort of aggressively keeping people in care, monitoring their medication adherence. The goal there, this next bullet, is essential. Viral suppression means that when someone's on their therapy and their virus is maintained, 2 things. 1, they're not going to get sick. They're not going to advance to disease. Equally as important, people who are undetectable, that is virally suppressed, are not able to transmit even in the absence of other protective measures. So undetectable virus, that is where there's not enough virus present to be detected, that individual, while living with HIV, having antibodies, is not going to transmit either through sharing injection drug equipment or through sexual contact, even with a partner who's negative. The other important focus is, and this continues, major metropolitan areas and southern states with higher rates of HIV. What we'll see in just a minute is a map that shows you those states that are of concern and those 48 counties that are most concerning. So I use the term care continuum here, and as I said, if you are going to reach out to partners, if you're going to think about funding, if you're going to go to the state health department and say, hey, we'd like to get in the game somehow of HIV prevention or retention and care, the conversation to have is how can you provide services that help address this care continuum. What you'll see is this is this is through the end of 2017. That's the latest good data we have. But of the 1.1 million Americans living with HIV, so 1.1 million Americans, 86% have been tested. That's great, but somebody's got to find those other 200,000-ish people who don't know their HIV status, can't benefit from treatment. So there's a bunch of people that don't know their HIV status. Of those 1.1 million Americans, only 64% have been linked to care. Linked to care is defined pretty specifically as went to an appointment, had labs drawn, so it's not just got a referral to treatment, but they went to a care facility and labs were drawn at least once. 64% of those 1.1 million, again, you should be seeing a trend here, of those 1.1 million Americans living with HIV, just about half went to an HIV care site, got linked to care, and have stayed in care. About the same are currently virally suppressed. So what this should tell you is a bunch of people don't know their status, and of those folks who found out their status, there's a whole bunch of people, hundreds of thousands of people who haven't shown up in care, haven't stayed in care. And part of why I think OUD providers are in an important point in the epidemic is I think some of your people are people who are falling through the cracks. When people ask me what's going on, I think about a colleague at CDC who sort of tracks who's not staying in care, and he says substance misuse is definitely part of untreated behavioral health. Is definitely part of who's not staying in care. So I want to kind of pull back and just sort of real quickly talk about how services are delivered. My apologies if this is familiar to you, but our goal on this webinar is to kind of increase your capacity to network with people in your state, in your county, and certainly for those of you interested in the rural HIV funding, to start thinking through who are the players, who's doing what. This next couple of slides is designed to give you the big picture. All health departments, almost all county health departments are engaged somehow. All state health departments except North Dakota. I'm not sure if they don't have sex or use drugs in North Dakota. I'm not sure what the story is. Any North Dakotans? There are any North Dakotans on the webinar? If you can explain why there's no HIV in North Dakota. For other reasons, North Dakota chooses to not accept federal money. That's all I'll say. State health departments almost all receive, some are smaller states, 5-6 million. California, I think, 20 million. Let me see. Efforts maximizing convergence of HIV, HCV, STI. Beautiful. Libby's talking about they're already working together because HIV, hepatitis C, and STIs. The movement is called Ending the Epidemic. Exactly. Libby, you're exactly where I wanted everybody to be. Everybody call Libby and ask her how they did it, because that's exactly what I'm talking about. Most health departments are pretty focused on HIV testing and counseling and notifying partners. STI services, sexually transmitted infections services, have always been involved in knocking on people's door. Hey, a previous partner may have exposed you, sort of conversation, why don't you go get tested? Most health departments, state health departments, have HIV care that runs through their office, and they support Ryan White Care in usually a mix of county health departments, medical settings, FQHCs. The state health department is typically not providing HIV care, but they're the grantee for HRSA. And so if you want to know where the money is going, you reach out to your state health department. Ryan White program, say, help me track where this is. There's SAMHSA funding that comes into states to do substance use treatment and prevention. A part of that block grant, that is money that goes to the state. In some jurisdictions, it's kind of a funny algorithm that they use, but depending on prevalence, there's 5% set aside for early intervention services. Again, that is screening for HIV, linking people to care. Those are early intervention services for around HIV. So again, you could speak to the individuals you work with at the state substance use behavioral health office and say, hey, do we or don't we get this SAMHSA funding through our block grant? Aid service organizations, most places have some kind of aid service organizations, often started as community groups. Some are, kind of coming from a faith-based perspective. Most do some kind of prevention, including syringe services program. There's a abbreviation I want to explain: syringe services program, SSPs. Usually needle exchange and other wraparound services. Some CBOs are doing HIV care, support groups, case management. Some of the larger ones have in-house behavioral health therapists, substance use treatment. It's not common that aid service organizations are doing medication-assisted therapy. It happens, but not often. Many times they're involved in the housing of people living with HIV, and some have pharmacy programs. That is, I'm a community-based organization, but I have a pharmacy program that allows me to buy, let's say, a drug at $10. We've got insured patients whose insurance company will pay $40 to me for treating that patient, and that $30 goes back into my profits from the 340B. That money has to be used in other program activities. The CEO can't capture it, but there's a lot of money being made in 340B pharmacy programs. And again, as you're trying to think who's doing what, if you hear somebody saying we're running a 340B program, that's an agency that's successful. Most likely that's an agency that's successful. So I use the term Ryan White Care Act. Most people remember Ryan White. The CARE Act's been around since the early 90s. What the CARE Act offers is core medical services, either provided by an entity or contracted. Some places they contract with a dentist or contract with the doctors if the doctor's not an employee of Palmetto Aid Services, let's make up a name, but rather so some people are going to be housed under an umbrella clinic, other folks are contracted out. So it's core medical service. There are 6 core medical service. Mostly it's primary medical, primary care, dental, medical case management, behavioral health. What's important is the case managers in Ryan White settings are always the gatekeepers. Sort of think of it as like any case manager. They're the ones who coordinate services, who link consumers to other service. What's also important from HRSA's perspective is for people to take advantage of Ryan White services. They are the payer of last resort. So insurance has been tapped out, Medicaid or whatever your state Medicaid-like program is. I'm thinking Tennessee has its own unique Medicaid, but those must be exhausted before Ryan White will kick in. There are federally qualified health centers and community health centers that are doing HIV care, and that is increasing. HRSA, that funds federally qualified and community health centers, has put additional supplemental money into HIV testing recently, and within the last year, some recent HIV testing came around. And there is also a move for pre-exposure prophylaxis PrEP funding for FQHCs and community health centers, available again through HRSA awards. So again, as you're kind of learning the landscape, going back hopefully from this webinar, learning the landscape where you are, who are your FQHC partners, who are your community health centers, what are they currently involved in terms of HIV response, and again, how can they collaborate with you? How can they provide services to your clients? How can your clients take advantage of those services? And then the last sort of broad category, I said earlier, some of the community-based organizations are providing housing. The housing HUD, Housing Opportunity, Housing and Urban Development, has a program for persons living with HIV. HOPWA funding provides emergency and long-term housing, and HOPWA funds are, again, typically administered through health departments, but they go directly to, the vast majority for services, go directly to community-based organizations, and sometimes agencies that have just been in the business of doing housing. Like we've been a housing agency, so we kind of take that on. Libby said earlier that they're involved in a movement called Ending the Epidemic, STI, HIV. In February, the 45th President of the United States, in his State of the Union address, said, I think we're gonna end this epidemic. Apparently some people were surprised that he said that, but he said it. And so there's an enormous push by the federal government to support the goals of ending the HIV epidemic. You'll see the very lofty goal down there at the bottom, 75% reduction in new cases. We're holding steady at about 40,000 cases. Good news, bad news, we're holding steady at about 40,000 new cases annually. Bad news is we're holding steady at 40,000 new cases. This year we'll have 40,000 Americans get HIV. Last year we had 40,000-ish. And then 90% reduction by 2030. So our work is cut out for us in terms of ending the epidemic. As you look at the current HRSA funding announcement, at the top it says this is an ending the HIV epidemic. Almost all of the federal money that I've seen advertised that related to HIV for the last 6 months, certainly probably for the last year, the first thing says, as part of ending the HIV epidemic, the following announcement. So all of your partners, all of your community partners, all the public health agencies that you're collaborating with are in the business of ending the HIV epidemic. And I invite you to join these. Libby's got a great line there. Being in a rural area, nobody else wanted to do STI and hepatitis, and so it just sort of landed in their lap, I suspect, for some of you. It's the same thing. In rural areas, if nobody else is doing it, you roll up your sleeves and say, all right, well, maybe we will be the hepatitis C agency after all. So I want to talk about all four of these and sort of how they're done, but broadly, get better at diagnosing, get better at treating, get better at preventing, and get better at responding are the four broad areas. I said 48 counties earlier and 7 rural states. Here's a map of those ending the HIV epidemics. I don't want to discourage people. If you're in, somebody's in Nebraska, I don't want to say there's not a conversation to be had. I think there are certainly other activities going on around HIV prevention, hepatitis prevention and care, all sorts of things. But in terms of the federal focus around ending the HIV epidemic, these 48 counties make up more than half of new infections. These 48 counties plus 7 states, I want to say it's 66, about 2/3. I think it's about 2/3 of new HIV infection happens in these places. And so again, the government has said, let's kind of go in, hit hard, put lots of resources. So surely if you are in a critical county or critical state, I know these counties are largely urban counties, but what strikes me is most of the statistical areas are 15, 20, 25 counties around. So don't be discouraged if you are in the statistical metropolitan service area. You ought to go ahead and see if you can't be providing services. Somebody said North Florida. Joyce, if you're close to Jacksonville, if you're close enough to Jacksonville that people can come get their Suboxone for you, then you're close enough to, I think, tell them you'd like to help. So in terms of the AIDS strategy, in terms of the ending the HIV epidemic, here's what's important. Get people on antiretroviral therapy. We've got great treatment that's available. It's one dose. Typically, it's one pill once a day. For those who've been around for a while, as Unica said, I've been around a long time and remember pill burden and lots of pills. Generally, it's one pill once a day for most people. So the pill burden, the burden of treatment. Bad news is it's lifelong. If you don't stay on your medication, the virus will continue to do its thing. So getting everybody on ARVs, again, for their own health and for the prevention benefits. As I said earlier, if I'm taking my medicine every day as I'm supposed to, and my virus is controlled, it means not only I'm staying healthy, but it means if I were to share needles or have sex with another partner, my virus being controlled would mean that I'm not infectious to my partner. So the other important tools are about good care, and so that means getting people on ARVs antiretrovirals, but it's also important to these models of retention and keeping people supported. Part of what you'll see in terms of some of the innovative models I'm going to show you in a minute is just instead of one that I love is instead of making people who are getting OUD treatment go to their HIV clinic, what about integrating? And there are programs that are on both sides. That is, in other words, OUD, someone's coming regularly for their medication assisted therapy, why not just have the HIV nurse there come at a certain point? Or here's the HIV clinic, why not have that be a place, depending on what else is going on, why not that be the place where OUD treatment happens? And so there are these models of integration that are really innovative, and I'd heard of the former, I hadn't heard of bringing the HIV nurse to OUD treatment before until it's a fairly recent HRSA initiative, but I think it makes a lot of sense. Getting as many people on PrEP as qualify. The good news about PrEP is the drug's available. Bad news about PrEP is the lab test is lab tests that are required to support it tend to be a little trickier to fund, and you get into some issues of paying for the other support. So, and new lab and epidemiological techniques really refer to advances in HIV testing. The idea here is testing sooner in the disease process. We used to say it can take up to 3 months for antibodies to show up. Current testing technology, within a few days, we're going to get a positive HIV test. And so with 4th generation testing, I think of a slide earlier, we now, with those advances, we can now detect HIV much sooner in the disease process. Again, get those people linked to care sooner, get those people using protection sooner. So, goal 1 of the ending the HIV epidemic, HIV testing, I talked about that. What I haven't talked about is a model of couples testing. If you look to the interventions website, you'll see a citation in a minute, but you'll see a place where we're testing couples. And so we've got, Bruce and Betty, let's bring them both in, or Betty and Barbara, and bring them in, and while you're both here, let's go ahead, bring you in together, talk about your joint risk, talk about where you've been, run an antibody test simultaneously, and go ahead and get you tested. Social network strategy is a particular testing intervention where we sort of use peer recruiters. I've not ever heard of this being used with individuals with substance use disorder, but the idea here is you find the right person, they recruit other people in their network to come in and get tested. The idea here is if you find the right index patient, someone with significant risk, their partners are likely to have significant risk, and everybody's incentivized. The index consumer is indexed for the number of people that come in, and everybody gets a gift card who comes in. So they give hey, go to the clinic and get a test. When they bring that, they get a gift card, and the index patient gets a gift card. PCC is a particular counseling intervention, sort of intensive prevention support. A lot of what we know in terms of enhancing services has a lot to do with what I would call enhanced case management model, sort of intensive case management. This is kind of a cognitive behavioral intervention. It's structured 3 or 4 sessions, getting people tested and doing risk reduction counseling. And then partner services, I said earlier, usually delivered by somebody in the health department, says, hey, I want to go out and knock on doors and say, you may have been exposed, be a good idea. So one thing that's important to understand in terms of HIV testing is, gosh, I can't even remember, probably 15 years ago, early 2000s, the government said routine opt-out testing for everybody in medical care ages 13 to 64 should be standard of care, The reason for opt-out testing is the introduction is, unless you object, we plan to do the following, rather than, well, do you feel like an HIV test or not? There aren't specific unique consents. In other words, you don't run and get the new HIV consent implied in the consent for treatment. And no intensive counseling prerequisite. Basically what happened is in the early 2000s, the government said, we've got, again, a bunch of people that don't know their status. Rather than waiting for them to self-identify, when they come into the system for medical care, let's screen those people like we do blood sugars, like we do hypertension, and that will be one arm of figuring out who's got HIV. Again, unless other risk factors are present, it's just routine screening. So again, that's screening once, but repeating annually if you are meet any of these criteria. So the goal was a routine screening of the general population, which frankly didn't have great success. There wasn't a lot of uptake from healthcare, and so there's a lot of people that didn't, particularly outside of publicly funded, private providers didn't accept the guidance, didn't really follow through with the guidance. But if someone is in any of these risk categories, including injecting drugs or shared works in the last 6 months, had sex with someone that could answer yes, basically continue sustained risk. So if anybody has sustained HIV risk, the idea was they would get offered repeat HIV testing. So fourth generation testing, probably more than you need to know, but again, this whole idea that recent infections, about up to 3 weeks can be detected. And part of what that means is when I first get HIV, it's likely that for a period of just after infection, I'm going to get a kind of viral illness a week or two after my infection, and that's called acute infection. Well, because I've been not taking care of myself, maybe I'm thinking of your consumers who probably just have periods of not feeling good based on how severe their opiate use disorder got. They didn't recognize, that there was a period of time they were feeling bad. Sort of often it's flu-like symptoms. They resolve usually in a period of less than 10 days, usually a week to 10 days, maybe a couple weeks, and then I feel okay. But if you catch somebody in that acute period, it's important because you can get them on therapy right away. Also, people in acute infection, what's happening is there's a great deal of viral replication happening. So these people are especially infectious. So part of what fourth generation testing has done is the technology allows us to catch people who are just infected when there's a great deal of viral activity, when people are especially contagious to other partners. And it allows us to say, hey, there's something going on. We see HIV in the PCR. We want to go ahead. The antigen test is positive. We want to go ahead and get you on treatment and have you be especially cautious with your sexual partners. Talked about 4 goals of the ending the HIV epidemic. Talked about antiretrovirals and core services. Intensive case management. I looked at the models for what's beyond sort of just offering a prescription. There are a number of different interventions, which to summarize are just intensive case management. I've worked places where they go out and pick people up, a lot of old school substance use kind of stuff where, I'm real old school substance use people. You go out in the van and pick people up and take them to a meeting. Like, oh, you're going to go to a meeting because the van's going to show up at 7 and you'll go to your 8 o'clock meeting. And so basically the idea is just kind of intensive. We're going to you, we're providing support. Some of that's peers, some of that's trained social work, but intensive support to keep people in care. Other behavioral interventions that all are about linkage, retention. Again, I'd call them various cognitive behavioral interventions. And I said earlier, a bunch of these adherence interventions delivered by peers, patient navigators, this really draws from the cancer support universe. Gosh, I think we're back in the 70s or 80s. Early on, the idea was individuals who'd experienced cancer were trained to provide peer support to other cancer patients. And so this whole idea has been around in various iterations for a long time. It's been applied in the past, and now increasingly there's attention in the HIV service world to how we apply this model. Again, back to that care continuum, that question, how are we losing, several 100,000 people who heard they had an HIV positive test and didn't stay in care, didn't stay long enough to get treated. Patient navigation is one of the interventions. And again, sort of figuring out how to keep people, identifying barriers, problem solving those barriers. And again, often delivered by people living with HIV. In terms of treating people, a number of interventions. There's the website I've stolen all this from. Somebody sitting there saying, oh man, that Jim is so smart. Jim was just smart enough to steal all these from effectiveinterventions.org. But various tools, part of why I take time to do this is it's really important as you think about stepping up to respond. The HIV response is really at a point where you've got to have some science behind what you do. And so anytime somebody says, hey, we're doing great work, we want to help, I say, that is so great. I want you to take time and figure out which of these evidence-based interventions, again, for those of you who've been doing substance misuse for a while, the sort of SAMHSA's guidance to use evidence-based interventions has been around for 30 years. In the HIV field, there's very specific kind of linkage, testing, adherence, and so this website, Effective Interventions, gives you the nuts and bolts of what the interventions are, links you to training. Some of the training's online. Full disclosure, some of it's probably pretty expensive, but a lot of it's available online. But as you begin these conversations, hey, we think we could collaborate with the community health center down the road. We think our treatment center could be doing HIV prevention. I want you, again, to encourage people to be building in language that addresses the federal priorities and thinking about pulling interventions from federal websites that basically prescribe, here's the way we think best practices exist. Again, a couple new initiatives. These are both, all these are from HRSA-funded website, targethiv.org. These innovative HIV practices, HRSA spends money, so HRSA funded these kind of special projects to kind of try some things out. These four, I think there's 8 or 9 on the website, but these 4 seem to speak specifically to what those of you doing rural OUD might consider. What about integrating buprenorphine into HIV care? Could you go to a care provider in the next county and say, hey, we do that, but we know how to do buprenorphine. We can help you with that. Linkage to correctional health, getting people out of correctional settings. Again, the idea is aggressive case management. Pick that person up when they're released, follow them until they're successfully linked and retained in care. Integrating hepatitis C treatment in HIV is another innovative treatment. I'm assuming some of you are in the hepatitis C treatment business or certainly are thinking about hepatitis C. And then, as I said earlier, integrating HIV care. I don't know the model well enough, but I just remember as I looked at it, I thought, what a great idea that people are coming for their opiate use disorder treatment. Why not have the county nurse there on Friday afternoon or whatever day is good and say, hey, by the way, Miss Teresa's down the hall. She's ready to figure out why you're out of care. Let's go ahead and set up that appointment. Let me catch my breath. See what questions exist. I think Robert is tracking questions in the Q&A.
Hi, Jim. It's John. Yeah, I'm.
Oh, sorry, John.
Oh, no problem. So we do have a question from Aaron in Southern Ohio, and he is saying, we would love to hear about your testing and outreach strategies for ending the epidemic. We would love to hear what you believe is the best practice for linking someone to care and then having them retained in care. So just a little bit of at each step along the continuum, some of your advice about that. His population is working with an injection drug use population.
Sure. Excellent. Aaron, here's what I'd do. If I were approaching somebody saying we're going to do best practices, I think I really would consider implementing social network strategy. Part of what happens, especially in rural areas, is you spend the money and you go to every health fair and every whatever else, and your return in terms of HIV prevalence at the county fair is not great. Okay, so I'm doing the county fair booth, and you know, I'm getting less than 1% seroprevalence. If you find the right people, so social network strategy says you're going to find the right people. You can say, hey, you, Bob, we know you're real social. We know you've been shooting all over the county. Bob, we're going to give you a voucher, and you take these 10 cards to 10 people you've shot up with. And any of them 10 people that come, Bob, you get another $6 gift card. All of them going to get a $10, I'm making the numbers up. All of them going to get a $10 gift card. So the idea of social network is you found the right person. So instead of going to the county fair and doing 100 tests, you find Bob and his 10 needle sharing partners. In terms of return, there are some studies that show 7, 8, 10% prevalence if you find the right Bob. If you find the right person and they're bringing their people. So social network strategy for HIV testing, I think, is important. Finding someone to help you with 4th generation testing. I think I talk about this in just a minute, but the intervention I do for linkages that I think the government wants us to do for linkage is ARTIS, A-R-T, antiretroviral treatment assistance, something. If one of my tells Google ARTAS and antiretroviral treatment adherence, I think I may have it here, but I do ARTIS. So in other words, if you're looking to say what's state of the art, you're going to do social network strategy, you're going to find the right people. Those people are HIV positive. You're maybe personalized cognitive counseling, but there's a lot of push at CDC to implement ARTIS. So an ARTIS is, again, it's a motivational interviewing based intense case management. So you're going to do social network strategy, target those resources. Aaron knows exactly what ARTIS is. Aaron, you answered your own darn question. If someone could spell out for everybody else what the abbreviation is, but yes. So social network strategy, you're going to be a wise steward of resources. You're going to find the right Bobs, incentivize them to get their friends tested. You're going to use ARTIS to link them to care. And so ARTIS is, again, for those of you not familiar, people are trained in motivational interviewing. It's an intensive case management model that. So that's what I do, and then hand them off to the right clinic, Aaron. You're good to go. I'd fund you for that. Good question. John, any other questions?
Yeah, one other question,
Sure.
Jim. This is from Peggy. She's with an ASO that does case management, HIV, HCV, STD testing, syringe services, PrEP referrals, and care. All of it is stymied due to lack of Medicaid expansion in their state. It has to be said there's just not enough funding for MAT, PrEP, labs, etc. She can find Bob, but ... So, any comments for you?
Peggy, I don't know if it's your decision or it's your boss's decision. It's time to get on the 340B bandwagon. If I was you, actually, Peggy, I'm going to say, next time you do staff meeting, whatever else, I was on a webinar, good looking bald guy said, please say it that way, good looking bald guy said, why aren't we doing 340B funding for PrEP? You know, I don't want to make light of it. You know, the bottom line is you're doing great work, but where's the money going to come from? I mean, I guess there's two options. You can get better at grant writing. You can deepen your relationship with the state health departments, other funders, but I know those are tough. The agencies that are thriving, Peggy, are agencies that figure out how to build a 340B program. There's a big prevention agency here in Asheville, been limping along with car washes and drag shows like every other CBO, doing syringe work, doing 500,000 needles a year, but kind of limping. They've got a 340B PrEP program. So in other words, they're buying drug for $1, billing my insurance for $20, and that $19 funds other services. I don't know if that's an option for you, but certainly following the money trail, like who gets Ryan White funds, where do CDC funds go in your county, or this internal conversation about, is there any way we could look to establish a 340B program? If you're not doing primary medical care, the option would be to open a PrEP clinic, to expand your PrEP efforts and put that 340B profit back into work in other places.
Yeah,
I'm gonna
Peggy
keep
just had a, she just had a quick follow-up, and then,
Sure.
and then I know you have more material, Jim.
No worries.
It says that the money is dependent on insured 340B prescription.
Right. So that, right, absolutely. The 340B, the money changing hands, if you've got a completely indigent population, that's tough. I mean, I think the nice thing about PrEP, and again, what's happening here at the prevention agency I'm talking about, they're seeing some insured patients come in that funding. But yeah, if you're talking about a totally uninsured population and they're really, right, you're billing Medicaid for what you can, I think then it sort of looks at where other Ryan White services, you make the case to whoever's providing Ryan White services to collaborate, whatever CDC HIV prevention funds come in through the state health department. So you're tracking the major funding sources are Ryan White Care Act funds through the state health department, usually down through local health departments or community organizations. So you're tracking Ryan White funding, you're tracking CDC prevention money. You're looking at your own opportunity again, depending on where you are. This HIV, Rural HIV Planning Grant's a $100,000 planning grant that's available. There are gonna be 10 awards. I can't help but think if you show off in the planning for this HIV response with this current announcement, I can't believe that HRSA is not gonna consider keeping you in business. So yeah, I mean, I think it's seeing where the money is, trying to collaborate with those people. But yeah, absolutely. The idea that you really don't have any opportunity. But again, don't be afraid. If you could get 5% of your 340B funding, the amount of money being made on 340B pharmacy is enormous, and even a little of that business would do a lot to help your other services that aren't funded currently. So I talked about prevention earlier. We talked about PrEP, access to condoms, and then again, behavioral interventions. So one thing I think that's really important is there's been a de-emphasis in behavioral intervention. So I would just say that, there are a number of, if you've been involved in HIV, there were a number of effective behavioral interventions that rolled out and trained. Those are really, people are pushing biomedical intervention, particularly one of these 2 oral medications. Descovy, recently FDA approved, I think that's just the end of last year, or Truvada. Both of these about 99% effective. Again, the manufacturers are going to give you access, but how are we going to get the labs paid for is a big question, especially Peggy's question, especially uninsured consumers. But you want to, where you have expanded Medicaid, where there are health plans available, you want to get people engaged. There are other compounds that are currently PrEP. We're not just pushing those 2 drugs. One, there's a lot of interest in long-acting injectable PrEP. No clear path yet, but the idea could get a shot. Think about Depo-Provera for teen pregnancy, for pregnancy prevention. What else is long? The injectables for people with serious mental illness. The idea, if I could get an injectable of my PrEP, and it's good for however long, 6 months or 3 months, whatever would be ideal, especially for people for whom adherence is tough. So that's who ought to be on PrEP. Those are the Public Health Service Task Force. That looks like pretty much everybody I know would say yes to these questions. So I don't know who you guys are hanging around with, but yeah, pretty much everybody I know would be a yes answer to PrEP. If you are someone interested in behavioral interventions, the strategy again is not we're going to make something up. It's sort of we're going to go to effectiveinterventions.org. We're going to go to the CDC website. We're going to look at these evidence-based or evidence-informed. They've been saying evidence-based, and there's another category of evidence-informed, but sort of these interventions from a menu say, well, who are our consumers? What's the appropriate intervention? Do we have to adapt this? And then where are we going to get training? Where are we going to get training? How do we stay faithful to the intervention? So it's all those requires. So here, Peggy, this is for you. What do you do? People that are substance use providers, part of what I want to do is specifically kind of pull out where people might look who are part of this. In addition to this current rural HIV opportunity that I've been talking about, SAMHSA block grants available. That includes hepatitis testing, linkage to PrEP, hepatitis vaccination, or hep C treatment. So if you are in a place where those block grants are available, and my apologies for not understanding the nuance. It used to be all SAMHSA block grants had this set aside for infectious disease early intervention. It's now based on prevalence, and I really couldn't wrap my head around exactly what the parameters are. So you go to whoever manages your SAMHSA grant in your state and say, hey, are we available, our early intervention services? CDC funds 65 states to do prevention. Most have some kind of substance use collaboration that's part of it. Increasingly, you know, there's this uneasy sort of, oh, we do HIV prevention, we pretend syringe services doesn't happen, and it's very uncommon. It's very uncommon that syringe services aren't increasingly part of mainstream HIV prevention. That's just, they're not step cousins anymore. They're doing the thing. So understanding social determinants obviously is important. Part of what comes up, as I said, the impact on people of color, transgender, and persons who inject drugs. And so again, I think you guys are in an important role as you start to think about expanding collaborations, enhancing services, to say we are routinely interacting with an underserved population. How can we collaborate with you existing agencies? What else could we write funding applications for? Robert Childs is on it, right there in your chat box. Some ideas about where people go who are looking to expand funding. Thank you, Robert. We're going to keep that conversation. Let me kind of do my last couple slides. Yeah. So Libby raises an important point. Part of what happens is the case is controlled, and Libby's talking about somebody who's diagnosed in San Francisco. The case lives in San Francisco, and so part of what's challenging, and nobody knows how to fix this, because with hepatitis C and HIV, wherever the person is diagnosed is sort of that jurisdiction owns the case. Let me do these last couple quickly, and then we're going to go through last round of questions. Data to care. So data to care is kind of finding those people. It's a surveillance strategy, finding people that are out of care and getting them linked back into care. Part of why I raise this with you is I don't think I've got a lot of epidemiologists on this visit, but I think you guys are in an important role to get people back into care. What I said earlier, you understand. So in order to do that, you say, we know about where care resources are. We're asking people, have you ever been tested? Were you ever in a clinic? And then you know what your health department wants you to do to get those people back into HIV services. Again, you guys are working with priority populations. National HIV/AIDS strategy says one of the goals of the AIDS strategy, increase the percentage of individuals who inject who are virally suppressed. As I said earlier, youth and persons who inject drugs are poorer adherers. So the idea that you could say, hey, we are approaching you because we know one of the indicators is reaching individuals who are injectors. And then this last kind of reminder is reaching people who are unstably housed. So this is your homework. I would love for you to print this off, and if you think there's merit to do this with other people in your agency, these questions, that's kind of an assessment, sort of what are we currently doing, who, particularly those of you who are thinking maybe we should consider applying for this rural HIV planning opportunity. These questions are essential, kind of who's doing what in town. So it'd be great to take to a staff meeting, kind of put forward to everybody and say, hey, everybody, if we were to think about expanding what we do in terms of HIV prevention or care, integrating HIV into what we currently do, how are we doing this? This would be a great exercise to do that. Let me catch my breath real quickly. What are your successes? I'd invite people back to the chat box if you would. And I've done a lot of talking. This was designed to just kind of throw things out there. But as you sort of analyze what you're doing right in terms of HIV prevention, care, integration, working with core partners, take a minute and go in the chat box, all panelists and attendees, if you would. And what are you doing right? I think it's really important that people take a minute. Celebrate successful programs. We've had people talking about HCV integration happening, syringe services happening. Robert's giving you some great funding. Anybody identify some current successes, things you're currently doing right that you'd like to brag on yourself about? Go ahead and do some bragging if you've got models. Anybody doing anything right you'd like to take a minute and think about? I'm gonna do one last round of questions while you're thinking about anything you do. John, any final thoughts or questions, comments? I'm watching the chat box. If you do have questions or comment down there. John, do you have anything in the Q&A box for me?
I do not at this time. If you give it just a second, and I think I know Unique is going to multitask us at the same time, where she's going to do an evaluation of the webinar as you're taking those last questions.
Excellent.
So,
no worries. Yeah, I'm here. I know people have a hard stop at 3. That's I'm gonna be here for a minute if you need to.
Hi, everyone. If you guys haven't seen yet, if you need to submit any questions, you can do that via the Q&A section, or you can also submit them through the chat, since Jim is monitoring that as well as we are monitoring the Q&A. Also, if you have not done so already, you have seen the webinar evaluation survey link that is in your chat box right now. At this point, you can actually click on the link and it'll open up your internet browser. You won't have to copy and paste it this time, so just click on the link and it should open up for you and you can access the evaluation survey. But we will stay on the line for a few more minutes, so that way if you guys have any questions, Jim can answer them for you.
You bet. And I'll do a question, a plug for your TELS. Your TELS can answer questions about the current funding opportunity. And so if anybody is curious, Carol, I'm glad it was helpful. Marsha, I'm glad you were here. Good. If you've got any follow-up questions, your TELS know how to find me. I'm part of the JBS family, so feel free to reach out to them. Again, I'm sure the funding announcement July 10 maybe. So you've got 5 or 6 weeks to pull that together. Rural HIV planning, $100,000, 10 awards. But somebody's going to get those awards. Why not some of our friends in the rural OUD program? Anything else before we stop? Last call, questions? Anyway, I want to thank Unica and John for helping me through the technical part of this. I want to thank everybody for making time for this. I hope something's been helpful to you. Again, whether it's that particular funding opportunity, whether it's just thinking about ways you can expand, ways you can provide better services to people that you work for. I hope there's been something that's been helpful. It's been my pleasure to be part of this, and I'll keep you all in my prayers. Please stay well. Please keep your head above water. I'll keep you in my prayers. Please keep me in your prayers. So thanks, everybody. Thanks, TELS. That's how you reach Jim at JBS.
Thank you all for joining us for today's webinar. You all have a great rest of your day.
Glad you were here, Megan.